Ramdai Om sir and all my colleagues. Today I'm going to talk about metabolic response to injury. This is very complex topic and this may not be a domain of us orthopedic surgeon. Better it is actually domain of some critical care specialist or medical person. But I have concised this topic so that we all could understand as we are more involved in all these injuries and trauma as an orthopedic surgeon, orthopedic and trauma surgeon. So, as we all know, human body may be considered as the most advanced machine on planet. This human body has most complex network of the wiring as nervous system. It has most robust, most dynamic framework of skeleton, and it has most dynamic and most faithful the locomotor system in the form of muscular system. So this is by far the most advanced machine on planet, and many of the modern day equipment, modern day machines has been designed from the inspiration of us human body. And many of these human body system, many of these human body machineries work in concert to maintain the homeostasis, that is the ultimate balance. This homeostasis in human body is damaged or disrupted whenever there is injury. So injury may be accidental, injury may be some form of infectious, or injury may be elective in modern day practice where there are many elective surgeries. So homeostasis means maintenance of near constant conditions in the internal environment in whatever conditions. The stress-free perioperative care helps to restore homeostasis following any elective surgery. And resuscitation, good surgical intervention, and good critical care after surgery are key to homeostasis after any injury. So we have to know that if there are larger injuries or more injuries, the time to return to homeostasis of homeostasis is longer, and with smaller injuries, the time to return to physiological homeostasis stage is shorter. So there nowadays there is a trend to our minimal invasive surgeries, because these minimal invasive surgeries leads to early rehabilitation and early return to normal life. Metabolic response is, as I've already mentioned, it is graded and evolves with time. As these two graph mentions, first graph shows that with major trauma, the metabolic rate or metabolic response immediately after trauma is very high, and it gradually goes into normal in a few weeks time or few days time. And the metabolic response closely follows the nitrogen excretion or nitrogen metabolism. That is very important to be known in this metabolic response to trauma, because this is the muscles and this is the protein that goes into degeneration, that goes into utilization to form various metabolites like glucose and other energy sources, so that nitrogen excretion or nitrogen metabolism also goes hand in hand with the metabolic response to trauma. Factors that stimulate metabolic response to trauma immediately after injury are pain, hypovolemia, and various circulating substances like hormones and cytokines. Whenever there is pain immediately after injury, what happens is this pain, that is the nociceptive stimulation, leads to the production of various types of neuromodulators, various type of neurohormones, various type of distant hormones and cytokines, which will then lead to increased metabolic responses. Also, whenever there are injuries or whenever there are infection or any type of surgery, what happens is there is some form of relative hypovolemia. So these hypovolemia also triggers metabolic response via various baroreceptors and various chemoreceptors. And third very important interlinked structure, interlinked factor that stimulate metabolic responses are hormones and cytokines. These may be distant hormones like adrenocorticotropic hormone, higher stimulating hormone, insulin, glucagon, and cytokines like interleukin 1, tumor necrosis factor alpha, etc. This picture demonstrates the stimulus by which the metabolic response to trauma goes in our body. Whenever there is injury, the afferent nociceptive pathways, the pain pathways are stimulated, and it goes and goes towards the hypothalamus, where the hypothalamus produces, and then hypothalamus produces corticotropin releasing hormone that stimulates anterior pituitary to secrete ACTH, that is adrenocorticotropic hormone. Also, it stimulates production of growth hormone, which then stimulates the adrenal cortex, which leads to formation of, which leads to stimulation to form adrenaline and cortisol. These two hormones in concert work to maintain the body metabolism, to change the body metabolism. That is, it increases adipocyte lipolysis and increases hepatic gluconeogenesis. These are all to increase the peripheral glucose concentration. This is because in early phase, our body will be more concentrated on survival of the vital organs, which are glucose dependent. And then it also stimulates the sympathetic nervous system, which then will increase the pancreatic secretion of glucagon and various catecholamine secretions, which will increase the skeletal muscle protein degradation, acute phase reactants, increase in acute phase reactants, and changes in protein metabolism. It also, this injury also stimulates innate immune responses, which in turn will increase the pyrexic interleukins like interleukin 1, tumor necrosis factor alpha, interleukin 6 and 8. And it also stimulates production of hormones like insulin, interstitial growth factor, and testosterone and thyroid hormone, which all leads to the stage of hypermetabolism. So uh, we may see these our regular trauma patients or regular injury patients as a case of trauma only, but these are salient physiological responses, metabolic responses that initiates immediately after injury, that will harm or that will benefit the body. So whenever there is injury, if we can alleviate pain to that patient very early, what happens is the adrenocorticotropic hormone release and all sort of these metabolic responses can be decreased. The harmful effects of these metabolic responses can be decreased. The minimum, the adequate or optimal metabolic response is always good to body after injury, but excessive response, metabolic response is always harmful. It has also been said that if there is excessive adrenal excessive pain, which in turn lead to excessive anterior pituitary stimulation of ACTS, that may eventually drain adrenal cortex, and that may lead to adrenal shock. So uh, simple pain management during injury or immediately after injury also can drastically change metabolic response to trauma. The purpose of this metabolic response to trauma is it helps to provide essential substrate for survival, because in earlier stage, as I have already mentioned, the body will be mainly concerned about survival of the vital organs that are brain, kidneys and livers. It also postpones the anabolism, that is, the body building will be stopped for a while, because all of the body system will be focused towards body survival. And it also acts to help optimize the host defense. So phases, there are various phases of metabolic response to trauma. It was described in 1960s, and these are A phase, flow or catabolic phase, and anabolic phase. So these are very complicated and very complex ones. So I have tried to compare with these phases with our day-to-day condition. So let us consider this injury, the flood in our flood, the natural calamity as an injury. And what happens in early phase, that is A phase, what happens is we people who sufferer of the flood victims are no more concerned about their future, no more concerned about their work. They are mere concerned about their survival. They try to accumulate whatever things that are remaining, whatever food that are remaining. So this is the declining phase, the recessive phase. So that is the A phase. A phase means the A phase is for survival. So then comes the flow phase, that is the action phase or the catabolic phase. What happens, the information about the flow reaches to upper authorities, and upper authorities come for response from various sides, from various concerned authorities. The help comes, and at this time the more and more resources pour into that calamity struck area. So they can plan for some future, and at this time the area is very very catabolic or very very active. And after that, the final stage is the anabolic stage, that is the rehab and return to normal. If this anabolic stage is well planned, or uh, if this anabolic stage is aided by good catabolic stage, what happens is we can return back to this normal phase in this population. But what happens is, if the metabolic response, or if these responses are not well managed, if these floods are not well managed, what can happen is uh, the previous whole of the town may be gone, and the people may be bound to be a refugee. So this same thing happens in our body. What happens is, F phase means preparation phase, or F phase means survival phase. Flow phase means catabolic phase, where there is hypermetabolism, there is hyperglycemia, and it all helps in maintaining the body system running. And it also plans, or it also helps to plan for future anabolic stage. So these are phases. The, the phases are shown in this table. F phase typically starts with within 24. The duration is for about 24 to 48 hours. If we do good fluid management, good resuscitation, the F phase decreases, but F phase is always there. The main role of F phase is conserve blood volume and energy, and it is the repair phase. It is the stage phase of survival. Physiological response that happens in F phase is there is decreased basal metabolic rate, temperature is decreased, cardiac output is decreased, hypovolemia is decreased, lactic acidosis is there. So this is the stage of rest, or stage of survival. As I have already mentioned repeatedly. So hormones that are involved in F phase is the stress hormones like catecholamines, cortisol, and aldosterone, that are first released immediately after any type of stage stress. So it is followed by the flow phase, that is a catabolic phase. It usually lasts up to 3 to 10 days, and it is the phase when there is mobilization of energy stores, and recovery and repair, start of recovery and repair starts in this phase. In this phase, there is increase in basal metabolic rate. It goes a further step front than the survival. That is, the basal metabolic rate is increased, temperature is increased, oxygen consumption is increased, and cardiac output is increased. Here, some anabolic and the catabolic hormones are increased, like cytokines, glucagon, cortisol, catecholamines. But though insulin is released here, relative insulin resistance is there in this phase. So there is good hyperglycemic phase during this period. So this is the period where the good resources, or good glucose and all other substrates are prepared for the final anabolic phase. An anabolic phase starts after about 10 days time, and it may remain up to 2 to 3 months. Here, the replacement of lost tissues, like those tissues like muscles and fats which were depleted during catabolic phase, are replaced. The nitrogen balance now becomes positive, and this is mainly mediated by growth hormone, IGF, and insulin. So what happens is, if this catabolic phase is not well managed, though it is good in short term, if this catabolic phase remains longer, that is the phase of increased BMR, phase of protein destruction, phase of fats destruction, remains for long time, that is, this is the body is being deteriorated in this catabolic phase. So if catabolic phase remains for long time, it is harmful for body. Various things can be done to help to manage the catabolic phase, which I'll be discussing in subsequent slides. Factors that increase metabolic response, that is factors that increases or deteriorates the body's metabolic response, are hypothermia. If the patient is the temperature is maintained, it is body won't waste its resources to increase the maintain the temperature of body. So it's our duty as a clinician, as a doctor, to maintain the temperature of the body. Pain should be managed, as I have already mentioned. Starvation is also very important thing that will lead to exaggerated metabolic response. So as much as possible, starvation has to be um, starvation should not be done. Even pre-op starvation in our pre-operative elective cases should not be longer enough than 6 to 8 hours. It is said that, and even if we have to prolong them, they have to be supplemented with the dextrose solution so that the metabolic response to this injury, that is the starvation, is decreased. Immobilization always increases metabolic response, so immobilization has to be decreased. As far as possible, mobilization should be done. Sepsis or any form of infection also increases metabolic response. And hypotension, shock, or hypovolemia all leads to increased and exaggerated metabolic response, which has to be controlled as a clinician or as a caregiver. Response components are maybe divided into physiological. As I have already mentioned, there is increased cardiac output, the respiratory rate increases, membrane transport increases, thus leading to edema. Initially, there will be weight loss because of loss of body proteins and body fats. Wound healing will be problematic. In metabolic responses, there will be hypermetabolism, gluconeogenesis, protein breakdown. All will lead to hyperglycemic phase because uh, the vital organs survives only with glucose. So there will be phase of increased glucose in initial phase of the metabolic response. Clinically, they will present as fever, tachycardia, tachypnea, wound inflammation, and anorexia. In laboratory features, they will be presented as leukocytosis, leukopenia, hyperglycemia, elevated CRP, and hepatic and renal dysfunction. All of these features closely relates or closely corresponds with SIRS, that is systemic inflammatory response syndrome. Some people even mentions the catabolic phase of metabolic response as a corollary or as another word for SIRS. So this is, if this SIRS can be well managed, the modes, that is multi-organ dysfunction syndrome, can be well managed, uh, can be prevented. So this is very, very important thing. So uh, this is another thing which is important for us orthopedic surgeon. We tend to we see lots of patients which are who are very seriously injured, that is the polytrauma patients. That polytrauma patient is considered to be a first hit, that is the first injury. This first injury initiates the metabolic response to that injury, and the catabolic response is the SIRS, that is systemic inflammatory response syndrome. So this systemic inflammatory response syndrome has its one uh, one phase, or it goes up and gradually it settles down. So if we tend to do the second hit, that is the surgical, higher surgical insult, as I've already mentioned, shorter surgery or shorter tissue trauma will have shorter time period to return to homeostasis. So if we plan to do early total care, that is prolonged 2 to 3 hour surgery or 4 to 5 hours surgery in these severely injured patients, in place of damage control orthopedics, what happens is the SIRS response, there will be another SIRS response, or there will be another metabolic response to this second hit, that is the elective injury. So the SIRS, the metabolic response, that is the SIRS, may exceed the normal variant or may exceed the critical lethal value, thus leading to very bad very bad response by a patient, and even we may lose the patient. So this is very, very important thing with consideration to orthopedics when we talk about the metabolic response to injury. So take home message is the metabolic response to injury passes through three stages, that is ebb, flow, and anabolic phase. Adequate pain control, nutritional and fluid supplements, shock management, temperature management are key for well management of these metabolic responses, so that we can have a good transition or well controlled transition from ebb to flow and then anabolic phase. Thank you so much.